Good morning, Peter. Nice to see you.
Good morning. How are you doing?
Good. Okay, I think we can go ahead and get started. My clock says exactly 7 a.m. Thank you everybody who's joined so far, and thanks for those who are joining. I know people are joining in fast and furiously. Believe it or not, this is the 23rd session of Children's Heartbeat. We started in December of 2020, so next month will be our 2-year anniversary.
Hello.
Thanks. So we have a great case today presented by Dr. Balaganesh from Tirunelveli in India. We'll come to that shortly. Our experts today are Dr. Peter Hesslein from Seattle and Dr. Ed Walsh from Boston Children's. Both of them have been experts on these sessions before and very familiar to many of you. Lots of experience, very experienced electrophysiologists, both of them. So you can see on the slide the endorsements for this program. PACES, which is the Pediatric and Congenital Electrophysiology Society. OHSU, or Oregon Health and Science University, which is our home base here. Hart University from Cincinnati. SADS Foundation based in Utah, doing great work in preventing sudden death. Project ECHO, which is the model that we follow. ECHO stands for Extension for Community Health Outcomes. It doesn't stand for echocardiography, by the way. And then Children's Heart Link, which is based out of Minneapolis and does a lot of great work in helping children with heart problems worldwide. So thank you to all these great organizations for supporting this program. And then we have had financial support from Boston Scientific and Medtronic. Thank you so much. So a couple of quick announcements. Most of you are familiar. Please send comments and questions through the chat feature. I just also want to remind you, and I'll remind you at the end, next month, unfortunately, the clocks change in the Western Hemisphere. And so the time will be different for those in the Eastern Hemisphere. So right now, for people in India, the time is 7:30 p.m. From next month, your time will be 8:30 p.m. So 7 o'clock here will change to from 7:30 to 8:30 p.m. for you. Another announcement is that next month's session will not be on the 25th, which is the last Friday, because it's Thanksgiving holiday here in the United States. So instead, we'll hold it a week earlier on the 18th of November. So having said that, we'll go ahead and get started. Dr. Balaganesh from India, please share your slides and get started on this really interesting case. Thank you.
So you're able to hear me?
Yes.
Good morning, everyone. I'm Dr. Balaganesh from India. I'm going to present a case about a refractory supraventricular tachycardia in an 8-year-old child. So this child weighs around 20 kg, had a history of sudden onset of palpitation, which lasted for an hour. He had past history of palpitation 6 months back, which lasted for 2 minutes. It resolved on its own. No medical, no medication, nothing has been taken. It's resolved on its own. No other significant past and family history. He was managed initially in a hospital and referred to me due to refractive nature of the tachyarrhythmia. The management information from the referring hospitals are as follows. They given adenosine twice. The rhythm converted to sinus for a transient period of time, followed by recurrence. Then they tried amiodarone bolus 5 mg per kg over a period of 20 minutes. And since there was no response, they tried cardioversion with 50 joules, which also had no response. So they started an amiodarone infusion 5 microgram per kg per minute for 5 hours. Despite that, the heart rate remained high, that is 160 beats per minute. Hence, referred to me for further management.
Okay, stop there. Go back. Okay, just with this information that you provided, let's ask our experts. So you're saying, go back one more slide. You're saying that adenosine had a transient response. So they saw it, but they didn't record it.
Yes, sir. They given adenosine twice, but the
Twice.
rhythm strip was not recorded.
Okay. So let's ask the expert. So I know this is a common question that comes up for me, at least people ask me this question. So let's ask Dr. Hesslein. Suppose you give 3 milligrams of adenosine and you get a transient response. Should you give a higher dose of adenosine?
No.
Good. Tell us why.
If it worked at the lower dose, then the problem isn't that it hasn't worked. The problem is that the effect isn't persistent.
So even the higher dose will be just as transient as the lower dose?
Yes, I would expect that it's a crapshoot either way.
Great, great. So next slide. So let me bring in Dr. Walsh. So Ed, first question. Do you think, let me go in a reverse order. Do you think they should have done the cardioversion or not?
We'll be talking about some other things that could be done. You know, if the equipment on hand was limited in terms of your drug options, it's not unreasonable. But I'll bet you there was a response. Maybe just for a beat or two.
Right.
That would be a little hard to see with the baseline of the EKG machine jumping all over after the shock. It's not wrong that there were some other things that could have been done.
Okay. I mean, you're taking a bit of a softer line. I tend to take a harder line on this. That if adenosine worked transiently and didn't hold the rhythm and the rhythm recurred, I don't see how cardioversion is going to do anything different, because they both basically do the same, which is they transiently convert reentrant arrhythmias. And so I usually say, you know, if adenosine worked, but then the rhythm recurred, just like what Peter said, just similar to giving a higher dose, I say there is probably not much point in doing cardioversion.
Well, I don't want to get too deep in the weeds about that. One of the problems with adenosine, it lasts very short amount of time. However, those first few beats back do still tend to have some first degree block, and it makes SVT a little more likely to happen.
Sure.
And that's not something that you see with cardioversion or pacing maneuvers. But yeah, I mean, that, like I said, there were some other things that I would have considered.
Okay. Next question to you.
You know, Balaji, I'd like to add a comment or two.
Yeah, please,
This is
please.
Peter again. First of all, once we get into discussing the mechanism of what we think is going on, I think I could imagine how cardioversion might not have worked, because if it were synchronized, it could land at just the right time to sustain or reinitiate what it was terminating. The second thing I'd like to mention as we're passing this slide is that the dose of cardioversion, I think, is excessive.
How heavy is this child, Balaganesh?
20 kg.
So it is. So it is excessive. So the typical dose is half a joule per kilo is, you know, is the starting dose. So I don't know. It does look excessive. But anyway, let's go. I want to ask Ed another question. What do you do if the amiodarone bolus doesn't work? Do you still start an infusion, or do you say, well, it's not working, let me try something else?
Yeah, I mean, I would have managed this child a lot differently. I think amiodarone, a lot of people are comfortable using it. It's way down the list on drugs that I would consider for something like this. And it also, it's okay to start I wasn't there, you know, and
Sure.
you had to be there, looking at the patient, looking at the family.
Sure.
and their anxiety, and you try what you're used to using. Once again, not a wrong thing. It's not the way I
Sure.
would have done it, though.
Sure, sure. So no. I mean this program is geared for people who are not electrophysiologists, and I think it helps them to know that most electrophysiologists regard amiodarone as a, either a second option or third option down the list, and don't reach for it as our first option. Would that be fair?
Absolutely.
Yeah.
Okay.
Okay.
I'd make it fourth or fifth, but
Sure.
That's me.
Sure. So depending on the electrophysiologist, but generally we keep it in the back pocket for a later option rather than goes right to amiodarone. And I think it helps non-electrophysiologists to know that that thinking that we do. Okay, next slide, please, Balaganesh. So here comes the actual rhythm. Okay, let's go to Peter.
I'm sorry, you said me?
Yeah.
Oh,
What do you
okay.
think of this?
I think this highlights a classic case of find the P wave. This is a narrow complex tachycardia with P waves that are they are present, but it takes some searching and a little bit of guesswork. I think probably the place I would start is in V2, where you see, following the QRS, a sharp little spike.
Yeah, right there.
This seems to be uncharacteristic of a T wave. It corresponds with something in V1 that's a little bit elevated. And if one pulls out your calipers then and measures that RP interval, if one guessed that might be a P wave, you could examine every other lead and figure out where the P waves are and how the axis might be. But I must add that this is not the clearest example of P waves, and it leaves in doubt whether the P waves could be elsewhere. If one looks at V4, one could surmise that there's a sharper P wave preceding the QRS rather than following the QRS. And so I believe this is going to be, the question that persists as we continue to evaluate this rhythm as to which are the P waves, but there does seem to be some kind of glitch that is similar to a P wave that is related to every QRS.
Okay.
So we're probably dealing with a narrow QRS tachycardia with a 1-to-1 AV relationship that by history is transiently responsive to adenosine. Okay,
Ed, do you agree with everything Peter said, or do you feel a little different?
Yeah, I'm a V4 guy here. I think that P wave is kind of sort of in between the QRSs. But
you think that the sharp thing in V4,
yeah,
right bang in the middle, is the P wave?
Yeah, I think so.
Okay,
but like Peter said, this is a little bit of a judgment call.
Yeah, so let me, my 2 cents is, and I completely agree with both of you. The problem here is the T wave seems to have a sharp component, right, at the very end, as seen in V3, V6 even. I think somebody in the chat pointed out V6. And the question is that the P wave on top of the T wave, or is that little thing that Peter first pointed out in V2? Also, there is something in lead 3, right after the QRS. It looks like the T wave wants to be a negative T wave, and something pulled it up a little bit. So is this a short RP, or is this a mid RP? I mean, bang in the middle, maybe even slightly longer RP is going to be the question here. And sometimes these are confusing. I mean, the general rule that I follow is the QRS complexes are easy to find, right? They're sharp and they're easy. The T wave is a sort of a broad, blunt, medium-sized wave, whereas the typical P wave is a rather small and discrete wave. And here it looks like there are two spots where there is some discreteness right at the end of the T wave, like you see in V3, V4, like you say, V4, you're a V4 guy, or is it that other thing? And that's going to be hard to figure out. So let's just take it as a narrow QRS tachycardia.
Yeah,
Who else
I'd
wants
say
to weigh
there.
in?
Yeah, apology. I'd say there are two important lessons from this EKG for the non-electrophysiologist is number one, the importance in trying to find P waves and sorting out their relationship with the QRSs. And the second is always be suspicious of right after the QRS. Don't ignore that because it's an odd place to find a P wave.
Thank you. Those are great pearls. Next slide, please, Balaganesh. Okay. So this is the question slide, first question slide. What would you do next? Repeat adenosine while running a 12-lead rhythm strip. Try IV verapamil, IV esmolol, IV procainamide, do an urgent EP study, or if you have other ideas, please mention in the chat. Hannah, please go ahead and put up our question. Hannah? Okay. Audience, please make your choices. Keep in mind that this is not trying to like catch you out or something. There might be multiple right answers and multiple wrong answers. What's happening? I don't see anybody able to choose. Okay. So 65% chose repeat adenosine. A few chose IV esmolol. Experts, please weigh in. What do you feel? Do you agree with the audience?
I do.
Okay. Is there any choice there that's, I mean, obviously other than an urgent EP study, is there anything there that's a terrible option?
No, I don't think so. I think they're all reasonable, but it's best to have some understanding of what's going on and some documentation as to adenosine response before proceeding with other medications.
Great. I think also, it's worth mentioning that electrophysiologists, maybe I should just say myself, love the 12-lead rhythm strip, what's called the Cabrera format. It's so much better than the standard 12-lead format that, where you're wondering whether this particular beat corresponds to that particular beat and vice versa. Having all the leads go by in a rhythm strip is so helpful. Next slide, please.
Balaji, really quickly.
Yeah, go ahead.
Any comments from the experts on IV verapamil, a calcium channel blocker in a kid?
Yeah, he's 8 years old, right? We generally tend to frown upon verapamil in infants and very small babies. What about 8 years old kids? Do you feel the same restriction towards verapamil as you would in an infant? Ed?
No, I think that would have been a very reasonable next choice. Nice thing about verapamil is it sticks around for 4 hours. So actually, I was asked to put some slides together, and I'll review some of these options at the end and
Sure.
why I would have chosen one rather than the other. None
Sure.
of them are bad. I would not do an urgent EP study. That's probably the only thing that I would take off the list, but we're talking about the tools that are on hand. I don't know if procainamide is available everywhere. There's a lot of countries that don't have it. We have it in the US, and it's a very good drug, as I'll discuss later.
Yeah, absolutely. Thank you. So you really, it's a question of what you have available in your pharmacy. Okay, let's go to the next slide. Briefly saw it. Okay. Who wants
This
to
was
take? Yeah, go ahead.
this was the ECG taken after the transient response to adenosine, and in the referring hospital.
Oh, okay. This is from the referring hospital. Okay, so they did make a recording. Great. Okay. Who wants to comment on this?
Well, I'll jump in because this one is kind of fun. Again, we've got a narrow QRS, almost identical to the QRS as we saw before. But in some leads, particularly in lead 2 and 3, there's a small upslope before the QRS that raises a question, could this be Wolff-Parkinson-White syndrome? Except that that little preceding bump is slightly variable in its timing before the QRS. It seems to be slowly emerging from the QRS. The other thing is, if this were Wolff-Parkinson-White with a PR interval as short as this, I would expect the QRS to be considerably more broad, that there would be a greater degree of pre-excitation. So I think that this is a red herring, that what we're actually looking at is a fusion of sinus and junctional rhythm. And that it is a red herring. But the other interesting thing, I think, that will perhaps be a matter for further discussion later on, is the bump in V3. Which is on the tail end of the T wave, which is a very striking thing and almost looks like P wave. In which case we would be looking at P wave with a very long QRS, not implausible if this child is loaded with amiodarone.
You mean long PR interval?
Yeah, I'm sorry, what did I say?
Yeah, you said long QRS, but that's okay. I just wanted to correct you just for the audience, so there's no confusion. Also, what do you think of this lazy sort of a broad, blunt something or other in V4? Sometimes you see ECGs like this and people wonder if that's a P wave. What are your thoughts on that?
It's awfully broad to be a P wave. It's not as sharp as I might imagine, particularly after an episode of SVT, but anything is possible, and it could turn out that's a P wave. Why we don't see it in the other leads, makes me think that it's a U wave or part of repolarization.
So U waves are so common in V3, and we think this is not a P wave. The thing in V3 at the end of the T wave is not a P wave. Would you agree with that, Ed?
Yeah. I would have read this exactly the same way Peter did.
Great. Thank you. Okay, next slide, please.
This is the recurrence ECG from the referring hospital.
So now this is after amiodarone. The SVT is back. It's a little bit slower. This is a great ECG, and just because he's there, I might ask Shu, I think has been commenting on the chat. Shu, do you want to say what you think about this? Or are you driving?
Yes, thanks. Great discussion. I think this is quite similar to the previous tracing, except now when I look at V1, one of my favorite phenomena is there, which is very rapid upstroke and downstroke within what should be repolarization. And my poor fellows always see me draw the action potential to remind them that repolarization is a very gradual and smooth process. So I think there's your P wave. I don't think you can with certainty know if the P wave is a retrograde one, or we haven't really excluded that the P waves could in fact be driving the tachycardia and atrial tachycardia. So I think that's the the biggest change. And of course, the rate is slowed. And we often see that with amiodarone, that you don't break the tachycardia, you just slow conduction everywhere. So it keeps going, but at a slower rate.
A question from the audience about this lead 3. What happened to the U wave, and what are we seeing in lead 3? Where is the P wave in lead 3? There's also something in lead AVL that stands out for me.
Yeah, I think there's deflection. Of course, you do in real life. I think all of us would have calipers and take a caliper from the onset of the QRS to the easy to spot deflections in V1, and then we'd walk around the whole 12 lead and see if it's a consistent finding or if it's just a spurious finding. And I think you'd find that the caliper distance in AVL and probably in lead 3 would align with the same the same P wave.
Okay.
I don't see any U waves, which I don't think you would expect at this cycle length.
Okay. Peter, so given what we have so far, in terms of order of probability, what would be your most likely diagnosis here? What would be your second possibility, etc.?
Well, again, we're taking it on faith that there was an adenosine response.
Yeah.
And if that is correct, and I would like to expand a moment on what Shu was just talking about pulling out your calipers and measuring the RP interval, if you will, in V1, where we now convincingly have a P wave.
Yeah.
If you apply this measurement back to the other leads, I think you can determine that the P waves are inverted in the inferior leads in 2, 3, and AVF, and that we are looking at most likely retrograde P waves, at least from bottom to top rather than top to bottom, which makes it a little more likely then that we're dealing with a reentry tachycardia involving the AV node. So I would say most likely AV node reentry tachycardia versus AV reentrant tachycardia. I think comparing this EKG to the prior one, I've had the opportunity to actually put calipers to these two. I think both the VA interval is longer than it was before, which that much is obvious. And also the AV interval is longer than it was before. So the reason this tachycardia is slower is because both antegrade and retrograde limbs are involved. Shu's mention of an automatic tachycardia is not ruled out here, but the adenosine response, I think, would go against that. It could have been that the adenosine response was just blocking down an atrial tachycardia, and so it was a pseudo response.
And maybe this is a question, let me ask Ed. If we think this is a short RP tachycardia and this is a reentrant tachycardia involving the AV node, mainly we are talking atrioventricular reentrant tachycardia, AVRT versus AVNRT. Would you have a preference between one versus the other?
Well, with amiodarone into the mix, usually in classic AVNRT, you don't see P waves. They're buried in the QRS. Usually in PJRT, I'm looking at the chat, the VA interval is very long. But PJRT, you got to be careful. I wouldn't call it PJRT, but there are pain in the neck accessory pathways. We just got finished taking care of an infant with very refractory but conventional accessory pathway. It doesn't have to be classic PJRT, and I can talk a little bit about that later. It's a spectrum. but this is what I would call pain in the neck, accessory pathway mediated tachycardia.
See, so you're answering the question in a long way, but basically you're putting your money more on AVRT as opposed to AVNRT. I know because of amiodarone, we can't be certain, but
Right.
Yeah. Okay. There's a lot of people making comments in the chat about PJRT. Well, this is clearly not classic PJRT, where so the way long RP is typically defined as take the two RR intervals, take the midpoint between the two, and the P wave should fall to the right of that midpoint. This is certainly not that. This is falling in front of that midpoint line, if you will. So this would not technically be a long RP tachycardia. So PJRT would be, or classic PJRT this is not classic PJRT. Would everybody agree with me, or anybody feel differently? I know Chris Anderson, I think, has agreed with me. Is Susan there? Susan, any thoughts?
Yeah, it's hard to argue with Ed and Peter, but I would say this would be kind of a pain in the butt, but typical AVRT. It's not classic PJRT.
Okay.
It fits best. We're always just playing the odds, aren't we?
Yeah, no, that's reality, right? So next slide, please, Balaganesh.
This was the ECG done at the time of arrival here. The echo was normal with a good LV function. The heart rate was around 160 beats per minute. 30 minutes after arrival, the rhythm spontaneously converted to sinus rhythm, and the child was on amiodarone infusion at that point of time. So again, the child had a recurrence. At the time, we recorded the rhythm strip showing the origin of the supraventricular tachycardia.
Ah, nice. Let's talk about this. Who wants to take this?
I love this strip.
Go for it. Go for it, Peter.
All right. So here we are again in sinus rhythm with, almost the pseudo Wolff-Parkinson White at the beginning. That is P waves melding into QRSs, but again, slightly dissociated. And in this particular strip, with sinus arrhythmia, the P wave is disappearing into the junctional rhythm. And then there's a premature, almost narrow QRS beat. And why there's premature beat is a little hard to be certain, but I would wonder, again, this is a kid who's loaded with amiodarone. I would wonder if the P wave that is buried in the last slow QRS actually conducts forward and causes that premature beat, and that triggers the tachycardia. The onset of the tachycardia is very interesting because all of a sudden, and I'm not sure if you can see my arrow, you probably can't.
No, we can't. Maybe you, yeah.
Okay, if you can put an arrow 2 beats down. All right, just following that QRS, you see there's a sudden sharp negative deflection that is not present in sinus or junctional rhythm.
Right.
And we've already been suspicious before that that's where the retrograde P wave is. And so that's what's triggering the tachycardia. So we've got the same narrow QRS.
Yeah. So the little deflection that goes below the baseline, right after the QRS, it's present in all the tachycardia beats, but not in the quote unquote sinus beats.
Exactly.
Balaganesh, you can put your arrow right there, right after the Q. No, see there you don't have it. There you have it. That negative deflection is most likely the P wave. And then there's that pseudo P wave, which is the U wave, trying to confuse you.
Yeah, precisely.
Yeah.
I think it's an important thing if you look at those that are sinus that have the T wave with that notch on them at the end.
Yeah.
That persists even in the tachycardia, so I guess it proves it's not a P wave.
Exactly,
Does
exactly.
that make sense?
Exactly, exactly. Great point. Exactly. Okay. So there was a mention by Sujata in the chat that at age 8, AVNRT is more likely than AVRT. I said I disagree. At 8, AVRT is much more common. Anybody wants to chime in on that? Just playing odds?
I was
I-
just trying to find the paper that came, in the 90s with Barbara Deal, and I don't think AVNRT is more common. I'll put the link in the chat.
At what age does that shift happen? Prince, you probably know the answer. At what age does that shift happen where AVNRT becomes more common than AVRT? I feel like it's in the late teens.
Yeah, I put the paper in the chat. So they only went up to 10 years of age, and AVRT was still more common than AVNRT up to age 10. So I think AVRT is probably more common. Somewhere in the teenage years is where that probably shifts. Probably late teens. I don't know the data that supports that off the top of my head.
Okay. Question in the chat, which I think Peter should take because you have been commenting on this aspect. Why are we confident that the left side of the strip is sinus? It looks to me like sinus, but merging into junctional for a bit. Yeah, go for it.
Yeah, that's exactly what I was trying to say, is that this is junctional rhythm with sinus rhythm trying to occur at a similar rate.
Sort of they're sort of isochronic. They're sort of melding into one and the other. Sometimes junction is a little faster. Sometimes the sinus is a little faster. Okay, next slide. Okay.
Adenosine 3 milligram.
All right. This is a great slide. I think
This shows, just the opposite. This is termination of tachycardia. And again, at the beginning of the strip, we have those sharp negative deflections following the QRS that are the retrograde P wave. And with, I'm guessing that, well, it says adenosine, that with adenosine, that sharp negative deflection prolongs a little bit and then disappears. And that's what terminates the tachycardia. So you see that negative deflection following the QRS is not present on the last beat of tachycardia, and it is slightly delayed on the beat before that. If this were an accessory connection tachycardia, if this were AVRT, we would not expect adenosine to block retrograde conduction. We would expect it to block antegrade conduction.
So you're saying that the block happened between the ventricle and the atrium. So it's
exactly
retrograde block.
Slowing and then block of the retrograde limb. Okay,
what else? Anything else you can learn from this slide?
It breaks to sinus rhythm, the P waves. Now we can see P waves preceding the QRS. There is a prolonged PR interval, which is a result of adenosine plus amiodarone, I'm sure. And then we see the PR shortening a little bit as the strip ends. So that's adenosine effect on both antegrade and retrograde limbs of the tachycardia.
Anything else, Ed?
No, we're going to go back and forth on this a lot. I mean, I'm still betting on this being accessory pathway mediated. And it turns out that about 20% of accessory pathways are adenosine sensitive. I don't want to get too much in the weeds here, but AVNRT usually is not this persnickety. It's usually not this difficult. However, I look at the length of the PR interval after the adenosine, and it's so prolonged that any accessory pathway worth its salt would have been able to go retrograde there. So maybe I'm wrong. But the clinical behavior feels more like a pathway to me.
Also, this clearly establishes that there's no antegrade pre-excitation, right? Adenosine would have unmasked any antegrade pre-excitation, and so we don't have antegrade pre-excitation. And I completely agree with you. The fact that it doesn't come back and echo back to the atrium is also against an accessory pathway. Okay, next slide, please. Okay.
Again, the heart rate went up. I tried 2 bolus doses of IV metoprolol with no response.
So you're back in the tachycardia. So now we are, we think we know what the mechanism is, but the tachycardia is still being difficult. All right. So let's, instead of talking about what this is, why don't we talk about what should we do next? Next slide. I hope it's a question slide. Did I put a question slide or did we? Yeah. Okay. What would you do next? Ablation, oral flecainide, oral sotalol, oral amiodarone, oral ivabradine, other. So go ahead and choose your second line. So amiodarone clearly hasn't worked, or at least it's just slowed the tachycardia. A beta blocker hasn't worked. Adenosine has only had a transient response. Can you show the results, Hannah, please? Okay. So let's ask the experts. Is there any choice other than ablation, which probably I would say, I don't think, especially with the ventricular function being normal, the child tolerating this, I think we have the luxury of time to try and find a drug option rather than just go straight to ablation. Is there anything else you would say is a bad option or a non-option?
Oral amiodarone is not going to do much if it hasn't worked IV. Maybe take that off the list.
What about oral ivabradine? I'm only putting it in there. I put it in there because we've had quite a few sessions where we've talked about ectopic atrial tachycardias responding to ivabradine, junctional ectopic tachycardias responding to ivabradine, etc. But this is clearly not. At least this looks like a reentrant rhythm. It's not an automatic focus. I'd probably take it off the list of drugs that's likely to be effective. Would you agree?
Never tried it.
Okay.
In this setting.
And then Shu is mentioning that the concerns about IV beta blockers, like IV metoprolol. Obviously, when you're in a situation like Balaganesh and you're struggling, you tend to try things. But what do you feel like an IV beta blocker here? Is that a bad choice? Is it something that should not have been done? Peter?
Well, I think this highlights something I've always felt very strongly, which is that pediatric AV nodes are amazingly strong. And what we've been doing in this case so far is trying to poison the AV node so it isn't conducting one way or the other. Whether we disagree about what the mechanism is, we are using primarily AV nodal agents to try and kill this thing. And what we've managed to do so far with the amiodarone is to make it stronger. I think if we go back to our discussion about PJRT, what makes it incessant is that there's slow enough conduction that it can persist and reinitiate even in sinus rhythm. And I think that's what we've managed to do with the amiodarone, is to slow the circuit enough that we've turned it into an incessant tachycardia. And so further efforts to poison the AV node, you're going to have to do it with a strong agent. I think beta blockers are almost useless under these circumstances. I have very little faith in that. And so, I might have chosen sotalol. I would worry about cumulative effects on QT interval, but so far the QT interval in this kid has remained perfectly normal even after the amiodarone. So I would have tried sotalol, but I agree we've got a situation now that is that we've probably made worse over time, and we're going to have to consider other agents and other mechanisms.
Shu, you mentioned digoxin. And you also mentioned your concern about metoprolol. Give us your thoughts, please.
Well, I know I have a bias and a comfort with digoxin, but I've generally had good experience even digitalizing patients. But I just back to what Peter's saying, I think some of these cases are particularly tough when we flip-flop between an AV node blocking strategy and a pathway blocking strategy. We go down one route but only halfway than the other. So I personally usually start with one limb of the tachycardia and go after it fully. So I usually start with digoxin, especially if it's a patient that's far away and I have to start this over the phone. And one dose of IV digoxin, and then sometimes that's enough that the subsequent dose of adenosine a couple of hours later is fine. Whereas I've found that the IV beta blockers, especially propranolol, metoprolol, they stick around a little bit, and so you have this negative negative effect that sometimes is there 2-3 hours later by the time people have gotten impatient and they want to start the next agent. So you get overlap of drug effects. So but it's great discussion, and it's so clear that there's not one obvious pathway here.
Okay. Anybody else want to say anything before we move to the next slide? Any of the EPs? And there's a little bit of discussion about ablation, whether we should go straight for ablation or not. And I don't think we need to get into that. I want to keep this more into the drug treatment arena. So let's go to the next slide. Okay.
Based on the initial EKG, I thought it would be PJ again started on flecainide. And after 45 minutes of oral flecainide, rhythm begins time.
So most of the audience chose flecainide. You also chose flecainide, and it seems to have had an excellent effect. Any thoughts on flecainide as the second line drug in, I think Shu, you wrote the paper, so maybe I should ask you, is flecainide, sort of the consensus choice worldwide on as a second line for SVT in children? Anyway, if it comes to drug therapy?
Well, first I have to give credit. I think Jim Perry actually wrote a paper called Review of the World Literature or World Experience with Flecainide. So hats off to Jim. But I have a comfort with it. I think it's a good agent. And what we haven't really talked about at all, and I think it's different in an infant, is is this child's GI tract working? So sometimes in the younger kids, we can't rely on the oral agents. In an 8-year-old who's sitting and chatting, then I think we could use the oral route, and I think flecainide's a good option. But again, there's a lot of institutions that really like sotalol, and I think use sotalol preferentially over flecainide.
Okay. In this case, flecainide seemed to have worked very well. Is there any more slides, Balaganesh, or is this it?
So this EKG done at 1 month of follow-up only on flecainide.
Okay, fantastic. And so the child is doing well on flecainide as a monotherapy?
Yes, sir.
Fantastic. Well, great outcome, great slides, excellent recordings. I think we'll go to Ed Walsh. The question really this case brought up for me is, obviously we all like to talk about what the mechanism is, but as I learned from a wise old pediatrician a long time ago, about 30 years ago, sometimes, you just give it a label that nobody can disagree with and then go on to treatment, because, the child basically needs treatment regardless of what the diagnosis may be. And so the question really that I wanted Ed, if possible, to address is, what strategies and what things should we do when you're faced with an arrhythmia, and what things really help guide us in terms of what drugs to try, and also keeping in mind that we only have a limited number of drugs in our hands. It's not like an unlimited list. How to go about in a semi-rational way choosing which drug to use in these sorts of difficult situations. So Ed, Balaganesh, you can stop sharing. I don't know if Dr. Walsh has any slides to share, but regardless, even if there are no slides, we can just talk about your experience and your thoughts.
Yeah, I put a few slides together that I hope are helpful. But in terms of diagnosis, I still favor an accessory pathway here. AV node reentry, boy, oh boy, to be resistant to IV amiodarone, I've just never seen that. And it would be atypical AV node reentry at that, because there's this so-called VA interval. You look at the timing after the QRS. In AV node reentry, you usually don't even see the P wave because it's superimposed. So this could be a conventional accessory pathway. The only thing that's peculiar about PJRT is that it's a very, very long retrograde conduction time. And it's a spectrum. I mean, when do you start calling it PJRT and stop calling it regular orthodromic tachycardia? It's the same substrate. It's an accessory pathway that can conduct retrograde. The physiology is just more dramatically slow in PJRT. And there tends to be an anatomic predisposition for the posterior septal region. But regardless of the mechanism, here's the dilemma. This is a reentrant tachycardia. We know that because it would terminate periodically. We know that because it would start abruptly. So it is reentry. And there's 3 requirements. And I think everybody knows this. You need 2 separate pathways. You need unidirectional block of the initiating impulse in one of the pathways. And I want to emphasize a zone of slow conduction. Right? If you zip around that reentry circuit really quick, you're not going to be able to go down the original limb because it'll still be refractory. So slow tachycardias tend to be stubborn. And let's assume for a minute I'm correct about this being an accessory pathway. You can, as Peter nicely said, you can target one or the other limb of the reentry circuit. And if you want to block the AV node limb, adenosine works for a very short period of time. Calcium channel blockers will work, beta blocker sometimes will work, and then you have sotalol and amiodarone. If you want to target the accessory pathway, your choices are different. You can use beta blocker, you can use sotalol, you can use amiodarone, but procainamide and flecainide are also on that list. Now, if you slow them both down in concert, you will have a more persistent tachycardia at a slower rate. So I'm going to take the common drugs off. So if you're working on the AV node, adenosine for the short term, but a calcium channel blocker for the long term. And if you want to block the accessory pathway, procainamide intravenously, if it's available, is a very good drug for that, and flecainide orally. So we can do a lot of argument about what the exact mechanism was here. Finally, it would need an EP study to tell the difference. But that's how I choose drugs. You choose one limb of the circuit. If it fails, you move over to the other one. And that's exactly what flecainide seemed to do here. And I will add one other thing. I probably wouldn't have done it in this patient, but if you have a very stubborn tachycardia that keeps recurring, despite medical therapy. Another option would be to drop a transesophageal lead. There is commercial equipment for this. You just do a few beats of pacing and it'll terminate the tachycardia. And we've had kids in our ICU where we left the lead in and the people at the bedside would just periodically interrupt tachycardia until you're loaded with a drug or whatever you need to do to get that patient better. Now, that's probably for someone with bad function. That wouldn't be for this 8-year-old boy. But that's nice equipment to have. And if you don't have it at your institution, I would talk to somebody who maybe focuses on electrophysiology and maybe have them look into it because it could be a life-saving tool. That's all I have.
Thank you. That was excellent, short and sweet, and really to the point. Few questions from the audience that I would like people to address. Does flecainide work for AVNRT? Peter.
Maybe. I have less experience with that than other drugs, but I would not expect it to be as effective as it has been in this case.
Ed, what do you think?
Well, what is AVNRT? It's still a bit of a black box. And there's probably still some atrial muscle involved in the reentry circuit. That being the case, flecainide works on atrial and ventricular myocardium. I've seen flecainide work for AV node reentry, tough AV node reentry.
Great. Would you shock this child if resistant to medications? I think we've addressed this a little earlier. Shu mentioned about myocardial stunning as well. What do you think, Shu?
I very rarely have to shock a patient, as we've talked about. It's whatever the slightly different mechanisms, if you don't have some medical control, the shocking is, you might get you a bit of time, but I think you'll be back to the drawing board pretty quickly when the patient recurs. So you have to have some chronic ideas up your sleeve.
I think you're being a little too gentle. I would have said no. No, no. This child is stable. There's no hemodynamic compromise. You've got the luxury of time. I would not shock this child. Okay, next question. Can transcutaneous pacing be done? Should it be done? Well, I don't understand the question to some extent. I think it brings up the issue of what Ed's talking about, transesophageal. What is the big difference between transesophageal and transcutaneous pacing, Ed?
Well, first of all, I don't think you can get transcutaneous pacing to go fast enough to be practical, but and I've never tried to use it for VT. The beauty of esophageal pacing is, first of all, you can record the atrial electrogram and you would know exactly what's P wave and what's QRS. So there would be, we were back and forth a little bit in the beginning of the EKGs, which was the true P wave. The other thing is it just captures the atrium, just the atrium. And it's safer in that respect. When you transcutaneous pace, you probably capture both. I've never used transcutaneous pacing for SVT, so I don't know if it would ever work. But I think it would be a little dangerous and very painful. I'd probably rather do a cardioversion than try to burst pace somebody out with transcutaneous pacing.
Agreed. I think I don't see a role for transcutaneous pacing. That it would pace the ventricle, and that is not what we want. Question from Bala Ganesh: how long should we continue the flecainide? Is there a role for ablation later? Obviously, yes is the answer, but how long, and how long would people wait before going for ablation in this case?
Well, it would be an elective ablation, and I never, if I have drug control and a patient is tolerating it, I would say the minimum weight would be 25 kilograms before I would consider doing an ablation. Everybody's got different thresholds. That's mine. And I'd prefer it closer to 35 kilos, to tell you the truth.
I am so glad to hear you say that. There's so much literature about 15 kilograms that really concerns me. I am with you. I wait for 25 to 35, if at all possible. If the child is well controlled and there's no rush to ablation. What do the other ablators in the audience say? Shu, what's your cutoff age or size?
Yeah, for elective, I agree, 25 kilos. That's where the, primarily adult-based equipment starts fitting. But I don't push them, so yeah, but 25 is for the folks that don't want to wait any longer.
Prince, is Prince still there? Yeah, Prince is still there.
Yeah, I'm here. So what I typically do is I tell the family, the PACE's guideline states that the risk is the same, once a child is over 15 kilograms. So if they're really, hot to trot, I sort of, let them do it once they're 15 if they're otherwise well controlled. But yeah, I'm trying not to push. And in fact, I'm like, hey, if the kid's doing well, we can certainly wait until they're bigger. Lots of families are a little more comfortable when the child is older, but I do sort of, use that society's statement as my cutoff.
Anjan.
15 kilos.
Wow. Okay. Anybody else? Muhammad says 25. So given that this child is in India and I don't know how readily available ablation is for you, Balaganesh, I think I would stay on the conservative side is what I'd say. Any other points about this interesting case that either the audience wants to make or anybody? We are finishing a little bit earlier than scheduled. Usually we go till about the 15 after the hour.
Let me push back a little bit on that window between 15 and 25 kilograms. Yes, the safety benefit is about the same if you start doing it at 15.2 kilograms. But technically, as Shu said, the equipment doesn't fit well. Around 25 is where things fit pretty good. And I'm not talking about vascular access here. I'm talking about the curves on the catheter. And I'm not a cryo person except in certain circumstances, but if you're a cryo person and you're putting that 7 French cryo catheter up there, it's stiff as a board. And trying to get that in the right spot in somebody who's 15.2 kilograms, I find it dangerous. It's not unusual to bang the AV node and have some transient AV block and stuff like that. So that's why I've adopted 25. And now being stuck on flecainide is one thing. Taking a beta blocker or taking a calcium channel blocker, I would probably drag my feet to 35 kilograms or 30 kilograms. It's easy then, and everything fits. 15 kilos, I've done a lot of them when the chips were down. It's technically harder.
Technically harder. Thank you. So other questions. What should we be concerned about with chronic use of flecainide? Are there any side effects or any cautions about the chronic use of flecainide? And any words about flecainide toxicity? Prince, you're the flecainide expert.
So, I mean, I wouldn't be as concerned in an 8-year-old. It's kind of a pain because you're taking it, ideally 3 times a day, potentially you can get away with 2 times a day. So yeah, it's a little more of an inconvenience thing. With toddlers, with the suspension, you have to be really careful. If a toddler just gets into their bottle and drinks it down, those can be almost impossible to salvage without ECMO. And those are really tragic. So, but again, an 8-year-old who's taking, they're not going to overdose, at least not intentionally. And again, it's pretty safe for for years of use. You know, as we saw on the ECG, the QRS isn't even that wide, and we've got good control. So I'd be less concerned about taking it until the patient and family are comfortable with ablation.
Great. And then there's a little bit of chat about, suppose this child is sick with severe LV dysfunction. Are there any options other than flecainide? And I see that Shu has mentioned digoxin. I would agree. I think the nice thing about digoxin is the one antiarrhythmic that is not negatively inotropic. And if you're dealing, or if you think you're dealing with AVRT or AVNRT, it's a really good drug to try. Would you manage differently AVRT with pre-excitation and AVRT without pre-excitation? Shu.
Not typically acutely. I mean, if you have the knowledge that they have pre-excitation, you're a bit more aware that if you put them into atrial fibrillation, or if they go into atrial fibrillation, you're going to shock them. But once you're down that path, I mean, you have the ability to shock them nearby. Everything we do might destabilize the situation, so you've got to be prepared.
Excellent. Any final thoughts, Peter?
Well, just reiterating what I thought about the presentation and the importance of recording the electrocardiograms when you're giving adenosine, of searching vigorously everywhere in the strip for P waves and documenting that relationship between Ps and QRSs. And again, I think this case is very interesting because, as we talked about before, the early shift to amiodarone was something that an electrophysiologist might not have done. And I think that's what in this case made things worse for a while.
Ed, I want you to have the final word, but I also want you to answer the two questions in the chat. Digoxin and WPW syndrome, can we still use it? I think Shu has implied that acutely it's okay if you're monitoring, if you have cardioversion available or defibrillation available in your back pocket. And the second question is, should you admit the patient every time and look at QRS duration when initiating flecainide? So if you could address those two questions, please.
Well, the digoxin thing is a bit like religion. You're either a believer or you're not. I'm not a believer, so I didn't even put it on my list of options, but lots of people still use it and get away with it. The second question's a good one. We always admit when instituting flecainide therapy, there are unfortunate guidelines that people will always quote. If you don't follow the guidelines, you're in trouble. Our pharmacists will not allow us to even write an outpatient prescription for flecainide. Has to be initiated inpatient. Have we ever had a problem inpatient? No. Have we ever had a problem outpatient because a compounding pharmacy messed up or busy parents gave an extra dose? Yes. So we do what we're told to do based on guidelines, but it's usually a pretty boring hospital admission for 48 hours. Same with Sotalol.
Have any of you started using IV Sotalol and a brief, like a less than 1 day stay as a test of the QT before continuing oral Sotalol at home? Or do you do oral Sotalol for 48 hours in hospital before sending them home?
Well, that's similar to what we do, but once again, we actually had an abstract. I think it may have made it into print. We never had a problem with the inpatient observation period. So we do it because we're sort of obligated. Now, if somebody's got bad function, that's a different story. You'd be a fool to start any of these drugs as an outpatient, even beta blocker, if their function was bad. But a kid like this, you probably could start it as an outpatient and get away with it as long as your dose was very accurate. There supposedly are some hypersensitive people with massive QRS widening and massive QT prolongation, but I haven't encountered one in a pediatric patient, but I'm sure they do exist. So it's not wrong to admit them, but I've been holding my breath waiting for a patient to have a problem inpatient and haven't seen it. Now, I've been around long enough that I remember quinidine. And when we were using quinidine for atrial flutter and for some ventricular arrhythmias, those I did see in hospital torsade. Those I did, including a patient who couldn't be resuscitated.
Wow.
They happened to have bad function to boot, but you know, even though we shocked them quickly out of torsade, ended up expiring. That was pre-ECMO days. Don't use much quinidine anymore, except in very certain circumstances.
Yeah. Short QT.
That's one of them. Yeah.
Okay, but I think we need to wrap up. So let's finish up with what's going on in the chat. Prince rightly points out, do not use calcium channel blockers with WPW. Thank you, Prince. Question from Mohammed, who's an electrophysiologist in Pakistan, by the way. At what dose of flecainide do you get uncomfortable? Is there a dose that makes you worried about flecainide?
Well, we have the luxury of measuring levels, and we usually like it to be in the mid therapeutic range. I mean, the units are at 0.5. But if your level gets above 1.0, then we back off. The other thing is we do look at the EKG. We have had some people with therapeutic levels where the QRS widened a little more than we were comfortable, and we cut back on the dose.
So the last question is also about, well, the last two comments and question. What is the dose of flecainide? I typically start at 4 milligram per kilogram per day in divided doses, and maybe go up to 5 and maybe to 6, monitoring levels and watching the QRS duration, like Dr. Walsh just said. And any increase of more than 20 to 25% from the baseline QRS duration would make me back off on the dose. And there's a dose per meter squared as well, which is on the chat. Shu, you say you don't admit patients for flecainide initiation. So tell us a little bit about your experience.
I mean, these are kids who have normal function, structurally normal hearts. Yeah, I've written it lots of times as an outpatient prescription, and you know, no concern. Bring them back for an ECG about a week later, or, you know, 5-7 days to make sure there's no untoward events. I think the age of the patient is such a critical factor. And when we're talking about infants, everything is different, including what we were telling the parents and their sensitivity. I mean, I've seen pretty nasty sodium channel toxicity in an infant, with very therapeutic doses. So I think, I don't know the answer to this. Prince will probably pop an article into the chat, but I don't know the genetic determinants of the sodium channel metabolisms like we have for some of the other drugs like the beta blockers.
I have done what exactly Ed described in terms of admission and being very cautious. I think if a patient had like one of those Apple Watches or something, and at least if I can look at one lead QRS duration and watch it every day at home, I might allow a patient to do that. But I personally don't know that giving it a week seems like too long of a time. Maybe that's just my conservatism coming through. Anybody else do anything? Anybody else do oral flecainide at home? Initiating oral flecainide at home in children? Susan, if you're still there. Mohammed, what do you do in Pakistan? We do every 5 to 6 doses on outpatient. Okay, Prince, propafenone, not flecainide. All right.
That was in reference to the article I put in the chat since Shu threw the gauntlet down.
Okay. Well, this has been a great discussion and a great learning experience. I think it's time to wrap this up. So again, going back to announcements, there will be, Hannah will be sending out an email with a survey. Please take it. It really helps us. Also, for those who came in late, next month's session will be on November 18th. So it's a week early. It's the third Friday of the month, rather than the last one because of Thanksgiving holiday here in the United States, and also because of the change in the clocks, because of winter time. For those in Asia, it'll be an hour later. So 7 o'clock here today was 7:30 p.m. in India. Next month, it'll be 8:30 p.m. for you. So keep that in mind. We will remind you of that in our announcement. So with that, we'll close this session. Thank you, everybody. Great discussion. Thanks to the experts. Thanks, Balaganesh, for a wonderful case with great recordings. People, if you have any other good cases, please make good recordings and contact us. We will be happy to feature your cases. So with that, thank you all and have a great weekend. Bye-bye.